changed pretty dramatically, and I now have a microphone. It's best with the microphone. Thank you. Okay. So, yes, we're very different, and today we also would like to throw out some new ideas at you to consult with you, to get your thoughts about some maybe disruptive or radically different things that we're thinking about doing in the future, and see what you think. I want to just first give you a little bit of an overview of the partnership, and I apologize to those of you that have heard this before, but some of you are new and don't really know about us. So the Partnership for Successful Living is a trade name. It's not an organization. It's a collection of 6 different nonprofit organizations, all of whom have the same board of directors. And I'm pleased that many of our board members are here today. The agencies that we have in this partnership, the 6 agencies, are all separate and distinct nonprofits, but work in a very close and collaborative fashion when it comes to individuals that we're trying to serve. Individuals approach us often with multiple needs at the same time, and the typical single-fire nonprofit has to take those individuals and offer them a referral to maybe 5 or 6 agencies to get what they need, and I think you all know how difficult it is for that to actually happen. So our model is based on really trying to have no wrong door for people. It's based on trying to have easy access to our services. It's also a model that's had many kind of beneficial attributes to all of us as we've tried to grow throughout the years. We use it as a model to share our different resources. So those of you in business understand back office functions, and we share things like IT, development, HR, grants. So the normal nonprofit struggles to have a part-time grant writer. They struggle to have a part-time bookkeeper. We have a CPA, a VP of finance that runs our organization with a whole staff of accounting professionals. In terms of grants, we have a whole team of extremely talented grant writers. This model allows us to apply for more grants than the normal single-file nonprofit because we have a wider berth of missions. And I'm really pleased to say that we've been blessed. In the time I've been here, we've been able to generate grants in excess of $150 million. That's a pretty rare achievement in the nonprofit world. There are many other benefits to those that we serve. It has enabled us to grow and add a whole array of different services, from things like dental and so forth that you'll hear about, that are just really difficult for people to access. And it's given us the capacity to add things that people really need and to also be agile as needs change in the community. So the 6 organizations are all kind of related in a way in that they have the right synergy to work with people who have the vulnerable populations with complex needs in our community. I won't go into all the detail. I'm trying to just give you a very high-level primer, and I want to extend to each one of you an invitation to learn more about the details about how we have made all of this work. Before you leave here today, we're blocking the exits. No. We really would love if you would just, if you have to leave early, just exit through the, we'll have someone give you a tour to exit through the building, and so that you can at least have an opportunity to see our $5 million expansion that just occurred in this building for our federally qualified health center, which is key to some of the concepts that we're going to be talking to you about today. Okay, so I'm going to move on from the partnership and just sort of leave that as an open placeholder for lots more. That's usually about an hour discussion just to talk about. So I'll just broadly also add that across the partnership, we serve around 10,000 persons a year. We have 82 programs. We have about 350 employees. Our budget is in the mid-20s, 20 million at this point. So a lot's happened here. So today we're going to talk to you about a new concept that many of you may have never heard about called a Behavioral Health Center for Excellence. That's what our aspirations are for. So next slide. I'm going to turn this over now to Carol Furlong, who's just going to talk to you a little bit about this particular slide. Are you hearing me okay, by the way? Oh, yeah. Great.
So I'm going to sit just so that you can see the screen at the same time. We wanted to give you some food for thought. We know that the New Hampshire hospital's readmission rate is twice the national average for psychiatric hospital admissions. One bed per year at New Hampshire Hospital, which is our psychiatric hospital again, cost about $1,000 a day or $365,000 a year. The community mental health center's annual cost per patient is $4,269, and that is only for mental health care. And we want to compare that to the cost per patient in our Harbor Care Health and Wellness Center, which is $549 annually, and that includes not only medication-assisted treatment, which is whose function is to treat opioid addiction and other addictions. It also covers the cost of primary care, dental care, behavioral health care. And as we go through this, you'll hear more about some of our other programs that assist us in performing these functions. Well, we're going to talk more about that, but the bottom line is, it shouldn't come as news to any of you that our mental health system is broken. And part of that is services are not being received at the lower local community level. So if people with a mental illness don't receive services in their local community, where do they go for treatment? First, they go to the emergency rooms. And we were talking earlier, some of us have worked in the emergency room in evaluating behavioral health evaluations, and we have staff who ran the access department at the hospital for 20 years. And that's where they first go for treatment, is the emergency room. Well, you know that the cost of emergency room treatment is much more than an outpatient session. And if they go to the emergency room and they need hospitalization or they need more intensive treatment, again, where do they go? If it's available, they'll go to an inpatient program. There aren't many of those available. And if they're not willing to go inpatient, then they have no choice but to refer them to New Hampshire Hospital. So for lack of local services, we end up treating too many people inpatient or at the state hospital, which is the last place we want to send them. Okay? There's very little choice for providers and consumers of mental illness services. The way the state is developed, and Peter will talk more about this, our mental health system is siloed. They have to go to a community mental health center in order to receive the range of services that they need. Next. So our community is struggling. The last thing we want you to think is that we are talking badly about our community mental health centers. The truth is, these are very good people. These are professionals who care about the services they provide, but they're stuck in a bad situation. They're stuck in a system that's broken, and they have few options. We know, let's talk about, the Greater Nashua Mental Health Center, which is the one we know more about because we work most closely with them. They are really struggling to meet the demand for all the services. In the past 2 years, we have had, of our current 1,100 behavioral health clients, those are only our behavioral health clients, 344 of them are former Community Council Greater Nashua mental health clients who cannot receive care there. They've tried. They can't access the services. And so in order to receive services, they now come here, or in many cases, case managers and therapists and psychiatrists at Greater Nashua Mental Health Center are referring them here because there just aren't services available to them. We know that the number of visits offered by Greater Nashua Mental Health Center has decreased by 75% during a 5-year period. Almost 75%. And we know that although that period was noted in a community health assessment done by Nashua, we know those services have not increased. Those visits have not increased. In fact, they continue to decline. Currently, the reports, when people come to us needing an appointment, we are told that it takes at least 2 to 3 months for an intake appointment. I'm sure you've heard these stories. And once they get an intake, it's then determined whether they need psychiatric services, medication services, and if that's determined, it takes up to 6 months to receive that care. So that may be 9 months that people are without the care they need in order to be independent. And where are they going in the meantime? They're going to the emergency rooms. They're going to the state hospitals, or we're losing them. These are the people that the police are called to offer services to, and crises, or the emergency responders.
So now we want to talk about how is it, what is our mental health system structured upon? A law was passed in about 1986 called 135C by the legislature. That law, I remember it because I was here at the time. I've been here, as I said, for 34 years. And it's basically a law that divides the state of New Hampshire up into 10 different geographic regions. And, you know, it says you have to create identical systems of care in each of the, kind of a clone structure in each of the 10 regions. In today's world, we have very different views of how behavioral health services should be delivered. There's a federal vision and there's a state vision. The state vision is based upon 135C. It doesn't matter whether there's an adequate population within that geography. In today's world, we talk about population health. Population health means that you look at the demographics within the area that you're trying to serve, you figure out how many people have those various characteristics, and then you tailor your services around that. This is a model that says, like robot thinking, to establish services. So, you know, I think you can go to the next slide. In 1986, it's a long time ago, it's 30 years ago, I was trying to remember what car I was driving. Whether it was a Ford Maverick or a Ford Falcon or whether it was the K car, I don't know. But a lot's happened, I think we'll all agree, since that time. And today, outside of the state vision, so you have a mental health system that's based on separate, segregated service delivery structures. So if you have a loved one, as I do, I have a brother with serious mental illness, and if I want him to access care, I'm going to, you know, he's going to go to a place for that care that's basically surrounded almost exclusively by other people who have serious mental illness. You socialize with, you go to your groups with, you sit in the waiting room with. Today, there's a federal vision, and I know when I use the word federal, that isn't always popular with a lot of people, so don't assume anything about what we think about when the word federal, but the bottom line is that the federal vision focuses on what's called integrated care. And the federal government believes that integrated care should occur in a setting where there's primary care, behavioral health care, a whole array of different services where teams of professionals work in partnership. And they look at the person from all different angles. So if somebody has a behavioral health diagnosis, maybe it has to do with some kind of infection or some other kind of medical issue or some too many vitamins, who knows. But it allows for a holistic, integrated approach in looking at things. So the federal vision, as I said, looks at population health, not geography health. The federal vision has Basically, the federal government has invested billions into strengthening federally qualified health centers across the country. They have invested in expanded mental health care, substance use disorder treatment, medication-assisted treatment. As a federally qualified health center, we ourselves have been the beneficiaries of, even throughout this year, every few months, additional revenues that are coming in. One other thing I want to say about the state mental health system, it's all of the mental health centers basically are operating in a structure, and as I say, they're good people, but it's a bad structure, are operating exclusively on Medicaid revenue. Medicaid revenue is 95% of the revenue. In a federally qualified health center, it's an entirely different setup. You have a base federal grant. In our case, it's about $2 million a year. And then you have other things that I'll talk about that also bring in revenue. And then you have your third-party billings that you do. So I'm going to just go back to you're going to see me sort of switching back between the two different visions, state vision, federal vision. In one of the single biggest challenges for the state system is the recruitment of professional staff. You've seen that they can't get psychiatrists, psychiatric nurse practitioners, and it's a major, major challenge system-wide. And so I'm pleased to tell you that we actually have a very robust staff. We have here with us today 4 psychiatric nurse practitioners. One of our 2 psychiatrists is here. Our medical director is here. And we have about 25 master's level professionals. And you're going to ask me, how do we get staff and the mental health centers don't? The answer is this. There's something called NHSC, National Health Service Corps, that federally qualified health centers like us can take advantage of. When you're graduating out of residency and you have $200,000 in debt at your school, they say, go to NHSC. Why do you go there? Because you can go and work in a place like us, and you can work off that $200,000 over time. And you can get additional stipends and so forth on top of your salary. And so our name, Harbor Homes, listed right on that website. And so we got a stream of people who come to us who are ready to come and be employed. So there are about 5 or 6 different advantages of FQHCs. And I'm going to not go into every slide, but you're going to sort of see things up here that will sort of back up some of the things that I'm saying. Can you go to the next slide? So I don't know if I got ahead of myself here, but these are some of the things that we now provide in the clinic or in our different programs. And you want to talk about that?
So Harbor Homes offers a variety of housing programs on a continuum. So we offer a shelter, an emergency shelter, several transitional veterans programs for homeless veterans. We have a safe haven program, which is a HUD designation for people who are homeless and need more intensive assistance. And we have permanent housing funded through HUD. So we offer a wide range. And one of our newest housing programs is the Bridge program. We administer the Bridge program for the state. It's one of the few sources of state funding that we get. And that Bridge program came out of the Department of Justice settlement, so that people who are being discharged from the state hospital or who have been incarcerated can immediately find housing. We assist them in finding housing, and then for a period of time offer case management to them along with the case managers from the Community Mental Health Center. One of the difficulties, as we'll talk about briefly, is it is only open to people who are referred by the Community Mental Health Center. So if they can't get into the Community Mental Health Center, how do they get referred to this program? We also offer stigma-free, accessible, and as we said, integrated primary behavioral and dental health care, all both pediatric and adult. And we say stigma-free because we know with our veterans population, for example, they don't necessarily want to receive or seek out mental health services. There's a stigma attached to that, especially for veterans. they can come here and come to our clinic, and no one is going to know from the outside if they see them coming in what kind of care. They could be coming for dental services as far as anyone knows. So we know that people are feeling more at ease in accessing our services. We offer some community behavioral health services. We are allowed as a community mental health provider, we're one of 2 in the state, to offer functional support services. And that's an incredibly important service in our vision. These are services that we provide to people with a severe and persistent mental illness in their homes and in the community. So we help them to ensure, we help them focus on their treatments and how to recover from those symptoms. We help them with budgeting. We help them with household maintenance. Now, we don't do that, but we prompt them to be able to do that so that they can maintain their housing. We help them find jobs. We help them with resume building and making those connections to services. We offer veteran services. As I said before, we have 3 transitional housing programs for homeless veterans, and we have a SAMHSA-funded program. SAMHSA, again, is Substance Abuse Mental Health Services Administration. We have a veteran program funded by SAMHSA that offers them counseling, case management, and employment services. We also have a homeless veteran reintegration program that's funded by the Department of Labor. Andrea Reed, who is here somewhere, manages that and has found jobs and helped veterans find jobs over the last 5 years. She's done an incredible job in finding jobs for veterans. 800 jobs. Sorry, Andrea. And we are beginning to provide more medication-assisted treatment. Our medical director, Dr. Sylvia, is a Suboxone certified provider. Our psychiatrist, Dr. Misra, will also become one. And as you know, you've probably seen publications in the Telegraph and other papers, we are now distributing Narcan and educating the community on how to use Narcan in order to address the opioid epidemic. And we work very collaboratively with Keystone Hall and our other agencies. One of the things that we take great pride in is that we all 6 agencies work very closely together, so that if Annette at Keystone Hall needs to refer someone to us, we roll out the red carpet for that program, and we make sure that they're immediately received. And the same is true for us, sending referrals to her or to the Southern New Hampshire AIDS and HIV Task Force, Milford Counseling. And then lastly, we offer psychiatry and counseling services to people in our behavioral health department. Yes. Thanks, Dean. The check's in the mail. And coming soon, if you take the tour, you'll see a section of the building where we have our behavioral health department. We are going to be moving behavioral health out of that area, and we're going to be developing in the spring a medical respite center. And the purpose of that, again, is to be able to take people out of the hospital. People, homeless individuals in particular, go to the emergency room. They might get hospitalized for something. They are there for the requisite amount of time, and now it's time to discharge them. But the hospital's not allowed to discharge them to homelessness. So they end up staying in the hospital for an extended period of time because there's no place to send them. Our thought is we can open up the medical respite program, get them there. They'll get round-the-clock medical care. We'll have nurses and case managers on the off shifts. Our clinical staff will be available during the day. We'll get them out of the emergency room. And while they're here, we'll work on case management and other services so we can find them an apartment and get them the services they need. We need to keep people out of the hospitals. That's for their betterment, for their independence needs, but it's also a state need to save some of that money. We have a contract with Walgreens to have a 340B pharmacy, which is an opportunity open to FQHCs to offer medications at some lower cost to consumers. And we will soon have an on-site 340B here, which again, you'll see on the tour. And then I want Annette to talk a little bit about how we integrate services here.
Hi, everyone. Can everybody hear me okay? I've been told I don't need a microphone, so that's the reason why I'm asking. It could be a little too loud. Keystone Hall is really fortunate to be part of the partnership. And I'm going to give you one example. So for us, we may have a woman who comes in who may be pregnant, who is abusing opiates, may have 2 other children, and we are able to get them right in, and they're able to access services from the partnership. One of those could be if someone has a co-occurring disorder, substance use and mental health. We actually are able to have some of the staff from the from Harbor Home Wellness Center come and meet with our clients there at Keystone Hall. We also work back and forth with the medical care. As you can imagine, once someone goes through the withdrawal process, they may have a medical issue that comes up or a psychiatric issue. And so for us and for the clients, it's actually worked out really well. The medication-assisted treatment, as you know, it has been something in the state of New Hampshire that we haven't had a lot of. And so the fact that we're able to access that, or the clients are able to access that right away, has been very beneficial for us. And one of the other things I also wanted to talk about, we have the Cynthia Day Family Center, which is the only program in the state of New Hampshire for pregnant, postpartum women with infants and children. And primarily for women who are opiate addicts who then become pregnant, it's a huge problem and an issue for the state of New Hampshire, and so we're able to house them there. And once they give birth, they're also able to get pediatric services for their children through the partnership. And lastly, Keystone Hall is the only substance use treatment facility in the state of New Hampshire that actually has a satellite of the Harbor Care Wellness Center right in the building. And believe it, we use it a lot. We absolutely do. And then we also partner with Milford Regional Counseling to provide also some other mental health counseling.
Thanks, Annette. So there's an unmet need in New Hampshire that I think we're all aware of, and we believe we're in a good position to help answer that unmet need. As I said, we're a state-approved mental health provider, which means there are some options open to us that others don't have. We have the capacity for substance abuse, medication-assisted treatment, primary, behavioral, and dental care. This is a one-stop shop. So people can come in here. Every person who comes in for an appointment, regardless of where they start, is evaluated, their very first appointment, for depression, anxiety, suicidality. So if you see your dentist, we're going to check that out and make sure you're okay. And if you're not, you're going to get a referral before you leave to a behavioral health specialist. Or as Dean said, he's a behavioral health provider, but there were some medical issues. They got an immediate referral. So you're going to get the care you need here very quickly. I frequently have to fill out surveys for managed care companies and other insurance companies about our access. I filled one out yesterday, and the questions are, you know, how soon do you have an appointment available for a routine behavioral health appointment? And the answer is within 48 hours. How soon do you have appointments available for urgent or crisis appointments? And the answer was, I filled out the survey at 10:48, which had to be noted, and at 11 o'clock there was appointments available. So people don't have to wait. Our staff have same-day available appointments that are mandatory because we're an FQHC. We have those services available. We're a healthcare training facility. Now you might ask, well, who cares? One of the things that we know, and one of the things we heard last week at a behavioral health summit from the community mental health centers is the reason they're struggling is that they cannot find staff. So Peter talked about our ability to use the National Health Service Corps. But because we are an FQHC, because we provide wonderful integrated care, we have so many schools and colleges and universities reaching out to us who want to send their students to us for training. So we have agreements with Dartmouth, we have agreements with Antioch, UNH, University of New England, Rivier College. We have a constant stream of trainees here. Nurse practitioners, doctors, master's level clinicians, medical assistants, dental assistants, and soon we'll be having dentist trainees from University of New England. That's a great opportunity to have. And we hope that if they like working with us, we'll be able to hire them once they finish their training. We're not allowed to turn anyone away. We don't turn anyone away. And so we might catch those who might ordinarily fall through the cracks. There's no wrong door. So if you have to go to a center that only provides behavioral health, those individuals are not trained to look for other issues. Because we offer integrated services, all of our staff are trained on how to evaluate for a variety of issues, and we work closely together. We have common supervision. We have common staff meetings where people can talk about how we do this better. And we're on the front line of the heroin epidemic through our integrated care and through multiple treatment options. We can provide services seamlessly that other agencies can't.
I'm sorry. And just on that note, I forgot to mention that our substance use outpatient department is going to be moving into the clinic so that the clients can better access our services.
Thank you, Carol. Thank you, Annette. So I guess that's what happens when you have good care. We really have had enormous growth. This is our patient volume for behavioral health, primary care, and dentistry. And the more the word gets out with patients in the community, more people are trying to access us. I want to point out one thing that Carol said about we're a federally qualified health center. We have to accept all comers, regardless of your income. If you're low income, you're allowed to access a sliding fee scale so that your cost of care are lower. But if you're not, then you pay standard charges like anyone else would. A second thing I wanted to follow up on that you heard Carol and Dean talk about emergency rooms. This is something that we aren't just talking about, but we know about. Why? Because Harbor Homes has had a contract with both St. Joe's and Southern for a 2-year period of time where we did over almost 4,000 behavioral evaluations in the emergency department. We also have a contract with St. Joe's for their psychiatry services. So if we can next, this is my favorite slide. I got ahead of myself earlier when I started to talk about the National Health Service Corps, but I think you can now see how that's a very key advantage. And the federal government has set FQHCs up with 5 or 6 very distinct operating advantages so that we're going to be strong in the future. As you heard me say earlier, we have an infrastructure. We got a $5 million grant to build out this infrastructure that you'll see hopefully as you exit the building today. And then there is something called the 340B pharmacy. You're probably looking at that thinking, oh, it's a pharmacy. Well, that's not how you should think about it. The 340B program is a federal program. And you hear me talking about all these federal programs. It's not that we're trying to sort of get things that we're not entitled to through the federal government, but this is the hand of cards that we all have, and you can decide to use your best hand, or you can decide to use a weak hand. But the 340B program, when you see it, you should see it and understand it as a revenue source. Way back in the mid-90s, the federal government made a deal with all the drug companies, the pharmaceuticals, and said, we'd like to be able to purchase our prescriptions at wholesale cost. And the savings from those wholesale costs get shifted to the FQHCs. So that's a revenue stream that actually could be enhanced enormously by the kind of patients that are seen at the community mental health centers. So it's a little complicated, but we have patients that we're able to do it. All the FQHCs make revenue from it. I was just talking to an FQHC in Vermont. Their net revenue for 1 year, after doing it for just 3 years, is $1.6 million a year. So this is a significant program with significant opportunities. And now that we're talking about money, you're probably thinking I'm here to ask you for some money. I'm not. I'm actually here to provide a discussion, to enrich the discussion, and to see if there aren't some ways that will actually save the taxpayer money as we increase our understanding and illumination of all the opportunities that are available. Okay, so FTCA funds. What the heck? Yes, Latha, good morning. Right, well, it's a very flexible program. You can have external contracts and you can have an on-site pharmacy. We're planning to do both. So, FTCA stands for Federal Tort Claims Act. Basically, the state of New Hampshire contracts with the mental health centers, establish Medicaid rates, and the rates that are established each year build in premiums for malpractice coverage. And I'll just also get you to think about one thing. There's a lot of talk about increasing capacity around medication-assisted treatment, working more with heroin addicts and so forth. Think about the impact on malpractice premiums on that highly risk of, it's a very high risk area of medicine. So if those same services that are delivered under the roof of if the same services that are now delivered by the mental health centers were delivered under the roof of the FQHC, the annual premium for malpractice insurance would be zero. The federal government has this FTCA program for all deemed agencies, and we're a deemed agency, so that they represent you in court. Any claims against us, which they might be more and more as we get more into medication-assisted treatment, so very, as I said, a lot of fatalities and so forth. So that's just one little thing. I don't know, honestly, what the cumulative annual premium for malpractice insurance statewide is across the mental health centers, but I'm sure it's not small and won't be small going into the future. As legislators, I'm sure you could find that information out a lot easier than I could. So there's also an enhanced rate of payment that we get. We get something called the encounter rate. So as a federally qualified, one more advantage we get. So we can bill, and we have different rules. We have a higher rate of payment we get that's based on the assumption that we're working with greater acuity, and it also helps in the operations. And then the last thing that I'll mention is that, and there are others I'm not mentioning, but we can propagate. So, which means we can create different satellites. You heard from Annette how Keystone already has one. a second satellite integrated within Keystone Hall. In Boston, there's an FQHC that actually has 70 different sites, satellite sites. So it's being nimble, it's agile, it's you move to where the population health need can occur. And I will tell you that if you think creatively about it, there's a lot of co-location opportunities within various systems of care that you can begin to think about. So we're here today really trying to throw out a new idea, a disruptive idea, an idea that we are not going to probably be able to be successful with unless we had your help. We are proposing that we establish a second community mental health center in our region, something that's never been done before in the state of New Hampshire, only for those persons who would elect to come to see us. In the mental health system, it's kind of an exclusive, I hate to use the word, but it's a monopoly. It's a regulated monopoly. It's a place where there never has been an ability for anyone else that had capacities to offer lower cost. And by the way, we are actually saying here that we are willing to deliver services at lesser cost and negotiate with Medicaid managed care companies than the prevailing Medicaid rates. So you can see that, let's see, where am I here? So we're trying to become a second community mental health center, and you heard that we're already what's called a community mental health provider. So under 135C, there's a term called program and a term called provider. We're a provider, a mental health center is a program, and a program can offer A to Z, the full range of services, and we as a provider can only offer the letter K. And as we now have about 350 persons with serious mental illness who are in our clinic that need care, they can't get care. They're here because they couldn't access it at the mental health center, who doesn't have enough staff. We want to have the permission, the approval to be a second community mental health program so we can provide all of our clinicians over there that you see. They see the pain and the struggle of the people who need that care, and we can't get that care. So maybe you can move on to the next slide. And this tries to illustrate to you, us we do the functional support as a provider. That's all we can do. If we were a mental health center, we could do all these other things that you see on the right. And it doesn't just have to do with individual, it has to do with duration, scope, and intensity of services. People with serious mental illness, I think you know, need sustained care over a long period of time. Okay. And I think I have Jennifer Patey here somewhere, who just walked right in, who's one of our wonderful psychiatric nurse practitioners who works with children and adolescents, and who's going to tell us a little bit of one quick story.
Sure. Okay. Just to start off, though, before talking about my work with children and adolescents, I am a National Health Service Corps provider. So I was hired here after looking at the National Health Service Corps website and contacting Peter and saying, what's this place? I was training in Boston and never thought that I would come up to live in New Hampshire. Where's that? That's so far away. And I had a 2-year contract, and it actually ended back in October, and I just signed on another year-long contract, and I'm planning to stay up here. My husband and I just bought a house. We love it here, and I love this organization. I feel like we do great work. We've really grown, in the few years that I've been here. But anyway, so I work with children and adolescents who have chronic, persistent mental illness. And I'm sure that all of you have a child or a grandchild or a nephew or a niece who struggled with depression or anxiety or untreated ADHD. And we know that that's heartbreaking and it's difficult and it just really stinks. And so working here in this community, been able to really help out a lot of the children here, but I see that there are areas where we are failing as a community in helping these kids. So I have kids who come over from Greater Nashua Mental Health Center. And they come over because they haven't been able to see their prescriber. They were active clients there, and then all of a sudden they call for an appointment and they say, sorry, we closed your case, you can't come back. I have one child, I'm gonna call him Rob. He's one of my favorites. He's 6 years old. He has a really significant trauma history. I won't go into it, but it's very sad and very disturbing. But he was taken in by his aunt. And so his aunt is really struggling with him. He's a great kid, he's a happy kid, but he has PTSD and he can be very violent. And he needs a lot of services. He needs case management, he needs in-home therapy, he needs intensive medication management and outpatient therapy as well. Here at Harbor Care Health and Wellness Center, we're able to provide for his medical needs, we're able to provide for his medication management and the outpatient therapy, but we don't have the services like the case management services and the in-home therapy that this child really needs. Those are services he's supposed to be able to access at the Greater Nashua Mental Health Center, but he's not able to get them there. They won't accept him back. And it's heartbreaking because I see this every single day with my work with these kids, where I am thinking to myself, I'm only providing a small percentage of the care that these kids need. And it's awful. It's really awful as a provider to feel like you're failing these kids. So.
Thank you, Jen. So now I want to focus on something that also brings this issue to the forefront for us, and that is the whole issue of the heroin epidemic in the state of New Hampshire. No, I'm not trying to capitalize on that, and yes, we're probably all sick of these round tables and don't want to do another one. But every one of us you'd have to be living under a rock if you haven't heard about the crisis in New Hampshire. So what's our solution? Who is it that we expect that's going to address or lead the effort towards bringing that to a better place in the future for the state? Is it the 10 community mental health centers, where 2 of them don't offer any substance use treatment services, and those that do generally offer minimal amounts? Is it the 18 substance abuse treatment providers that contract with the Bureau of Drug and Alcohol Services? Recently I was in a meeting where we were all there, and we were asked by the state, we have some additional resources coming up because of the crisis. Anybody here would like to add that capacity to become medication-assisted treatment providers? Only 2 of the 18 said that they would be interested in doing it. To do those services, you have to have a significant medical infrastructure. It's a serious undertaking. The 2 were Annette, we're one of those 18, and one other who's going to work with the hospital up north. Is it the hospitals? Are the hospitals going to help lead our way out of the whole heroin epidemic? I don't know about you, but generally I think the hospitals feel ill-equipped to address it. And when we have persons with heroin addiction go into the emergency room, generally they are trying to get them out as fast as possible, to be honest with you. The only other entity by default that's left are the 12 federally qualified health centers, who already are being given resources by the federal government to start and strengthen their capacities around that. And I've outlined for you some of the advantages that federally qualified health centers have in carrying out various services. So I ask you to think about that. I also ask you to think about this. The state of New Hampshire invests $112 million a year in Medicaid funding in the 10 community mental health centers, where they serve 14,000 seriously mentally ill folks. The state of New Hampshire invests in substance use treatment contractors probably about $3 million. I think they serve around 60,000 people. For the federally qualified health centers, we serve, the 12 of us, about 80,000 patients. The state of New Hampshire invests $2 million. So I'm not asking necessarily for more, but I just think that it should be weighed in the overall perspective of things. And I think we're at the point where we want to see if anybody has any questions, see if we can have a dialogue. And we'd be happy to answer. Anybody? Latha?
When you talk about a second
Right. Your constituents, who I know you care deeply about, would have the choice to go to a place where they can access care readily in a stigma-free manner. People who come in this building, nobody knows if they're a legislator or they're a person with serious mental illness. And that is... Who said that? Yes, so that we're talking about choice. You know, and when you have, all of you in business must know that when you have a monopoly on something, there's a certain culture. But when you have competition, you all of a sudden say, let's get the act together fast. Okay, yes, any other questions? All right.
So when you're saying that, perhaps proposing a second community health center.
Mental health center.
Would that be in this facility?
Yes.
In conjunction with the provider, Harbor Home?
Yes.
So you would be both?
Well, what we're
So
going
you'd
to...
be building a new place and a new...
So being loyal to our integrated theme that we're talking about, we would have both Harbor Homes and Keystone Hall be the applicants to become a second community mental health provider center for those persons choosing to receive our services. And we would do it here in this building, where we already have the infrastructure. We just have to move out all of our sort of administrative business staff and so forth to make room for it. Yes.
Is there already a legislative service request for new legislation submitted? Because you were earlier asking for possibly for enabling legislation.
We haven't we're here today just starting the conversation. We are consulting with you to see what you think about this idea, to see if it makes any sense to you. And if we get a sense that all of you may want to support this, or if maybe there's something we're not thinking of that we're missing, so we want to hear about it. And I think our objective is by the end of January to submit a full application for that to go forward and have a letter from hopefully as many of you that are willing to do so that would accompany the proposal, asking for a fair and full consideration of the proposal on the table. That would be our plan. I need to explain one other thing before I go into further questions, so that I don't want people to feel that I didn't mention something very important. So what I didn't say is that since the 1986 law, a lot's happened. The Affordable Care Act is in place, mental health, substance abuse, and parity is in place. We now have Medicaid managed care. There have been numerous court decisions, and actually one involving us. You probably know that we sued the state of New Hampshire, and the case went to the Supreme Court, where the Supreme Court ruled in our favor, ruled in our client's favor. 4.5 years ago, there was a decision made that 170 people that we were serving that were Medicaid enrollees had to shift their care to another provider. And we, along with Disability Rights Center, the Supreme Court ruled that patients have a choice. And now we've also had a second ruling 100% in our favor, saying the state didn't follow all the procedures. And now we have a damages trial that's scheduled to be going forth in the spring. We don't want to, and so we lost around $10 million of Medicaid revenue that we would have billed during that time. You're entitled to your net losses. In our case, it would be about $2.3 million. We don't want all of that money, and we would like to be able to better serve our patients. That's what we want. And we've said to the Attorney General's office in our negotiations, we want to become this. And they say, oh, you can't do that, you have to apply. And that's where we are today. That's the second thing that's brought us to this place. Okay. Phil.
Peter, I've been on the board for about a year, and as I listened this morning, I realized that this is a really information-rich hour.
one thing is, will you be able to sign a letter of support to come, and endorse this concept of a second community mental health provider in the region? Let's see, you haven't had.
Yeah, I just wanted to know if you are planning on handling the whole state as people who are any place in the state take advantage of your services, or is there a second facility that would be?
I think one step at a time. I haven't told you this, but Harbor Homes owns 30 some odd properties. We have one in Claremont, Salem, Antrim, Manchester. So we're already doing things in sort of a statewide basis, but we want to do things the best we can in the greater Nashua area. There are opportunities, not just us, with the other FQHCs that could occur to be better deals for the taxpayers and better deals for the patients.
Thanks for taking the question. It's obvious to me, I think, that, especially after what you just said, that Nashua isn't the only place that we're looking at long-term. But would it be fair to say, that one of the reasons that you can be successful in a city area as opposed to a rural area is the fact that the people that you need for staffing are available? But how would you address this similar situation as this in Colebrook, for example?
Excellent question. The National Health Service Corps has a system where they kind of score every part of the world, and if you're in a rural place, it's more of a medically underserved area, there's greater incentives to bribe staff to go there.
That's true.
Right. It's still, I don't want to under...
of medical people in Colebrook, New Hampshire.
Yes.
And it sounds to me like between yourselves and other providers, you're using everyone
Right.
that Nashua can provide.
Right, but you have to know that there's also federally qualified health centers in those areas operating now, doing a great job, and they also have opportunities that could be forged ahead there as well. Tim?
When I hear you talk about an application in order to become another mental health service provider, does that mean just filling out a form and submitting it to like HHS or something, or does that mean changing state law somehow?
As I said, this has never been done before. 135 basically, 135C says there's going to be one mental health center in this region. It names the cities, and the first legislation actually names who the providers are. We would have to apply to the Bureau of Behavioral Health and submit an extensive application with our credentials to do so. There could be legislation. There's nothing that preempts the possibility of legislation in any way here. But we're just trying to kind of go through the accepted process. I can tell you that it's not going to be easy. There's a very high amount of energy and investment in keeping the mental health system free of change. Yes, speaker.
In answer to your direct question, while I've learned a long time ago, never commit to doing anything till you've seen the details, I would certainly be very supportive of signing that letter, and I would think that there probably isn't a legislator in this room who wouldn't be. And I've certainly been very impressed by what I've learned today, and really like your model and like how you're looking to move forward. So I will certainly say that anything that I can do to be of assistance, I will be glad to work with you. And I just can't imagine that there, again, anybody from either the House or the Senate who wouldn't be, because this is what we need. I think this is some of what some of us have been talking about, is that there's a lack of coordination. You've got people doing one thing here and somebody else doing something else someplace, and there needs to be that synergy. You're bringing that together, and it's very impressive what you're doing. And so whatever I can do, I'll be glad to assist you.
I thank you for that, and on behalf of all of the people that we're trying to help, thank you.
Yes, I've got a question. This is not my area of expertise. I'm a science, tech, and energy guy and an education person. So if I can just ask this question.
Can we ask anybody that has to leave to try to just make sure you exit through the right doorway? Sorry.
So if you're going to be setting up something like this to be assisting with the drug problem, we're not talking so much about MDs as we're talking about certified mental health professionals, possibly working with nurse pracs. Is that correct?
No, that's not correct. In order to provide a lot of the medication-assisted treatment, or all of it, you have to be an MD. You have to be an MD. So we have, we have our medical director who wants to say something to that. This is Dr. Sylvia Savanovich Kalken, who is a Suboxone provider.
I thought it was some question about the medical assistant treatment. Medical assisted treatment, it has to be provided for an MD or for a DO. The federal law doesn't allow nurse practitioners or physician assistants to do it. It's a really complex process because we have to really be sure that the patient is ready to stop with the addiction, and we can begin with the treatment. And they are on the long way. Some of them, they have relapsed, and we have to go through and we have to continue treat them and with different providers and different other resources. One of the big resources we have in the IOP at Keystone that we are happy that they are going to move here at the end of the year. And our patients are going to be here in the clinic and going to IOP in the same, which also they will take out the stigma, not to go into another place when everybody knows it's IOP. They come to the clinic and they move just to do their sessions. The other thing is, if they have a medical problem, they are seeing here, and if they need psychiatric medication or if they need a counselor, they are seeing in here. And the way to expedite, at least for us, is different than somebody who offers Suboxone in a separate entity. I just, in the same day, I could do the same appointment day for a psychiatric attention, for a counselor, and the patient goes totally support for every part that it can be. And this is very important also with the pregnant women. I have 4 pregnant women in the plan. 2 already have the baby. There are another one that is in the 20 weeks, and it's a different challenge. But these people cannot be in treatment if we are not here.
Thank you very much. Wow, lots of good questions. That's great. I want to say thank you to Dr. Rich Bowler, who is the CEO of St. Joe's, who has worked in partnership with us in so many ways. And I know that he also is very supportive of what we're talking about here today. So I don't know if you've had coffee, but absolutely. We'll get your questions momentarily.
And thanks for including me, because this is such a vital point for us. And I don't know if there's anyone here from Southern New Hampshire Medical Center, but this is probably one of those times that I can speak effectively on behalf of acute care providers in this region. Can't always do that, but in this particular situation, happy to. Access to services for us is critical. And what Harbor Homes is proposing to do and what they've done already, and they have a proven track record of success, is really integral to
the health of our community. When you look at the needs assessment, the community health needs assessment that I pulled off the shelf the other evening to look at again, there is no more critical factor in our environment than access to behavioral health services. And I come at this from the perspective of a critical hospital in the region, but also from a large ambulatory network. We employ over 100 clinicians and are scattered in this region. Access to behavioral health services is our number one need. We're not well equipped to manage the problems that we encounter. They are major confounders of medical illness, and when you look at the literature, the contributing factors for health of mental health to medical illness is extremely high. So we're eager to have your support to help build the program here, and I hope you'll see a way to help fund going forward. So thanks for your time.
Thank you very much, Rich. Okay, sorry.
No problem. Is the existing mental health provider in the city now on board with you trying to make application to be in competition with them? I'm sure the very last thing that you want here is a food fight in the city.
How do I answer that? Let's just say this. We have many of our board members here, and they can tell you about a variety of efforts that we've made to reach out to their board, to communicate, and have not been able to have success. You know, and even if we are able to kind of, there's no way that they won't get to, that they'll get to a point that they'll think this is a good idea. It's competition. You know, it's a disrupting kind of a proposal.
Thank you, Peter. I think the opportunity in terms of our community is the need that you very well eloquently established, that what our community need is. And we have two organizations. You have the federally qualified agency status, which you are able to draw a different source of resources to our region to address multiple issues: mental illness, addiction, and primary care for all population, and also your big effort in terms of ending homelessness, how well that was addressed in terms of a short period using different resources. I wouldn't look at it as a competition, direct competition, trying to take somebody else's food. This is the need for our community. We are providing two wonderful resources to the need. There is more need than what they can, what one agency is able to fulfill. So it's not, we have two vibrant hospitals. Is, you know, as competitive, but they are both thriving. So that's the way I look at it. This is an opportunity for Nashua to showcase that we can take the lead in providing the most critical need in our state.
Thank you, Latha. And one other thing I forgot to mention is the high point of kind of an operating structure to deliver such services we're talking about is when someone is both an FQHC and a community mental health center. The behavioral health conference we had last Friday, they pointed to 3 model programs in the country, all 3, both FQHCs and community mental health centers. All right. Yes.
Quick follow-up. So I mistakenly showed up at your emergency shelter before I showed up here. And so they explained to me.
They treated you well.
They did, and they gave great explanations. You know, for example, one of the things that they mentioned was that, you know, often when a patient is released from an ER, they go there. That saves the entire system an awful lot of money, because instead of occupying a very expensive hospital bed, it costs less money.
Very excellent point. And actually, emergency shelter is, we're big on what's called housing first. We want people to get right into permanent homes that are safe and affordable. And we're not talking about what's called social determinants of health, but we also do a tremendous amount in that area. We have 900 units of housing. We'll talk about that some other time. Other questions? David, oh, sorry, you haven't had a chance.
Thank you so much for doing this. It's just amazing. I didn't know what you folks all did. I'm concerned with a couple of comments I heard that said there's, we'll call it a funnel effect, that somebody comes in from another agency or tries to get here and either they're not allowed to come here, or in the case of the young lady who was there earlier, said she had a child whose case was closed and they wouldn't reopen it. Are there legislative issues involved that tie that up that we could help change either through rules or through legislation?
HEM 426, that needs to change. That's where they provide exclusivity. HEM 426 and HEM 403. It's State of New Hampshire Rules, Health, Education, Mental Health. The name has changed, but the people are the same over the years. Yes, 403, 426, 403. David Greenwood.
403 talks about the fact that there are 10 mental health agencies and you can only access those services through those 10 agencies. 426 talks about
And I put Dr. Misra right here and would love to be able to prescribe those services.
I wanted to ask about the reauthorization of Medicaid expansion, a big issue for our state in the coming months. If the expansion is not reauthorized, how would this affect your programs?
Excellent question, and thank you, David, for that. I want to say that we are going to have a forum here where we're going to answer that in more elaborate detail on the first week in January, on Wednesday at, I believe it's 5 o'clock. And the answer is that it would have an effect for those people who have, I think it's 40, 50,000 that are now on the New Hampshire Health Protection Program. All of those folks would be very adversely affected. And we wouldn't have insurance reimbursement for any of the services that they would need. We would still treat them and have to as a federally qualified health center, but it would just be sort of more of a burden on us trying to figure out how to pay for it all.
One option, the legislature is supposed to be considering both private insurance as well as expanded Medicaid. Is there any preference as far as you're concerned?
I think that we're already working towards a system where there's going to be a subsidy that people will be able to access it through the commercial marketplace. So private insurance will be an option. In terms of the people that we are most concerned with, we work with people who are desperately poor. We just, you know what I'm talking about. They need to have the benefits from the Medicaid program, and they are going to be imperiled if they do not have them.
This would be state-assisted.
Right. But, for people that have the means, the more, all the better, more power to it. We need commercial insurance too, so.
It's a matter of how it's handled.
Right. And we accept commercial insurance, although it's a small part of what we do. Any other questions? All right. Well, okay, so we have one last of you. So please walk away thinking about, could you support this? Know that we're going to be following up with each one of you individually. And we're asking if you would kindly just take a brief tour through our facility so you can kind of get a sense of what it is that we actually do. And so why don't we start by asking you to go out that door right there and follow me. Thank you. Thank you. Thank you so much.